18, urinary system. And there are, as usual, there are certain parts that are important to know. This part, which is the general function, is actually important, very important to know. And because of this, we will see later on the abnormalities. So what's the function of the urinary system? We know that common sense, urinary system, make the urine and get rid of it, right? Get rid of it. To get rid of what in the urine? The metabolic waste products that we will talk about. Metabolic waste products. Something like ammonia, urea, and others. This is one thing. The other thing is you get rid of also drugs or any toxins. So you're getting rid of two things. Number one, waste products, metabolic waste products. Number two, drugs. You get rid of them too. And also remove hormones. So you're removing those three. At the same time, you're secreting some secretions, including erythropoietin. There is another one that's not, we will see it, it's renin also. So there are two types of secretions that we need to know, erythropoietin and renin. I'm focusing on the most important, you need to know this. So what do we remove by the urinary system? Waste products, hormones, and drugs, okay? What do we secrete? We secrete two hormones, erythropoietin and renin. Both of them are secreted by the kidney, even though the kidney is not an endocrine system, but it does secrete two hormones that we need to remember. Activation of vitamin D occur in the kidney as well. So if something wrong happened to the kidney, you cannot activate vitamin D, and this will be a problem. Regulation of the blood pressure through the renin-angiotensin-aldosterone system that I talked about before, and I'm going to repeat it because it's important. So here is the other secretion, which is renin. So what are the types of secretion? Erythropoietin and renin. Erythropoietin to stimulate red blood cells formation. Renin is for angiotensin-aldosterone system. What does that mean? What's the renin? So here's the kidney. And it secretes renin and erythropoietin, which is EPO, abbreviation. What's the renin? Renin to increase blood pressure. EPO to increase red blood cells. What exactly is happening with renin that you need to know? Renin activates angiotensinogen to angiotensin 1. Which will be activated to angiotensin 2. Okay? What's the function of angiotensin 2? So angiotensinogen is inactive. Gen, anything end with gen is inactive. So it will become angiotensin 1. Which is a little bit active, which will be converted to angiotensin 2, which is very active. Now, what are the functions of angiotensin 2? Number one, secretion of ADH. Number two, secretion of aldosterone. Number three, thirsty, stimulate thirsty. Number four, vasoconstriction. Actually, vasoconstriction, you can get it from the name. It's called angiotensin. Angiotensin, what's angio? Prefix, that means what? Blood vessel. And tensin means tension, right? What's tension? When you make tension on the blood vessels, mean you contract. Contract, vasoconstriction. So basically the name means angiotensin means vasoconstriction. So this goes without saying. What else? You stimulate thirsty, so you drink more. Aldosterone and ADH. What's the function of each one of those? ADH, increase water reabsorption. Aldosterone increase sodium reabsorption. I'm not wasting the time, okay? This is important to know. Angiotensin 2, ADH, aldosterone, thirsty, and vasoconstriction. Why are you doing all of that? Let's take it one by one. Vasoconstriction. When you do vasoconstriction, what happens to the blood pressure? Increase or decrease or stay the same? Increase. That's number one. Thirsty. When you feel thirsty, you drink. So the blood volume increase, right? You drink, the water goes to the blood. So the blood volume increase. What happens to the blood pressure when the blood volume increase? Increase. That's number two. Aldosterone, increase sodium reabsorption. What's the sodium reabsorption? You reabsorb sodium again from the kidney. The sodium go to the kidney, start to show up, and the renal corpuscle start to show up in the tubules, and then you take it back because you need it. This is reabsorption. So what? So when you reabsorb sodium, when you take sodium back, automatically that will be followed by chloride, just like a shadow. When you reabsorb sodium, chloride is the shadow of sodium. So you're taking back sodium and chloride. Sodium and chloride is salt, isn't it? Sodium chloride. So when you take back salt, water will follow back as well. So now you're adding sodium chloride and water to the blood, right? The blood volume will increase, and the blood viscosity and osmolarity, both of them will increase, increasing blood pressure, and this is number 3. Number 4, ADH, increase water reabsorption. When you reabsorb water, when you take water back by the kidney, you're increasing the blood volume again, which increase the blood pressure. So what are all these 4 together? Increasing blood pressure. Increasing blood pressure. Did we get this point? When do you secrete renin if you want to increase the blood pressure? When? When the blood pressure drops. Make sense? Blood pressure drops, so the kidney receive less blood. Is that clear? Blood pressure drops, kidney receive less blood and less oxygen. It will release renin, increase blood pressure. So this is the reaction of the kidney to increase blood pressure, and this is one of the functions of the kidney. All these functions. Last one is regulation of electrolyte acid-base balance, and this is also important. Regulation of water. What regulation of water means? Means you reabsorb 90% of the water, 95%, 97%. How much? Depend on your needs. Depend on how much blood you have, how much water you have in the blood. If you're dehydrated, if you have less water, you reabsorb more. So you're regulating. Electrolytes, what kind of electrolytes? Sodium, potassium, calcium, hydrogen, bicarb, any one of those. Acid-base balance, you're playing with hydrogen and bicarb. Kidney, here is the pH exactly like this. Just to make it closer to your mind. pH, the normal pH, which is 7.35 to 7.45, I consider it something like gray. Perfect gray, okay? And if I want you to keep the pH, I'll give you 2 colors. One of them is white and the other one is black. And I tell you the following. I want you to keep this gray perfect. If you see it getting darker, add white, right? If you see it getting lighter, add black. Compare that to the pH. If you want to keep the pH as it is, you have 2 components to work on. You have hydrogen and bicarb. If it is getting acidic, you will add bicarb. If it is getting alkaline, you add hydrogen. What do you mean add? Add. Reabsorb. Reabsorb. Did you understand this concept? Because we will use it later on. So how is the kidney regulating the acid-base balance? It plays with the 2 components that regulate the pH. Hydrogen and bicarb. So what should the kidney do? The kidney should reabsorb bicarb and get rid of hydrogen under normal circumstances. But what if it is getting alkaline? You will not lose as much hydrogen. So this is like a water tap. It is controlling those 2 factors in order to keep the pH within normal. Okay? The urinary system consists of kidney, ureter, bladder, and urethra. Obviously, the kidney, we talked about all the functions. Ureter, take the urine from the kidney to the bladder, where you store it for some time until it is half full at least, and you need to go to the bathroom. It goes out through the urethra to the outside. This is a gross anatomy. Where is the location and everything? In this part, do you guys remember the kidney? Did you do the kidney before in A and P? Okay, so just a reminder that this outermost part is called the capsule. This light part is called the cortex. This part, that is alternation between pyramid, column, pyramid, column, pyramid, column. All of pyramids in columns together, this is called the medulla. The tip of the medulla, which is this is called the renal papilla. This is where we make the urine and leave through this. Go to the minor calyx, major calyx, renal pelvis, ureter. Okay? Just to refresh your information. You will see some questions like these. It's not all pathology. Some chapters have A and P that's very related to the pathophysiology, so this is something that we will need to know. Now, what's the nephron? Nephron is the functional unit of the kidney, and the nephron, we have millions of them. The nephron consists of renal corpuscle and tubules combined. What's the renal corpuscle? It's glomerulus and Bowman's capsule, which is like this. Like a tuft of capillaries like this, surrounded by this. This is glomerulus. This is a Bowman's capsule. This is afferent. I don't know how much exactly you remember from this, but if you know, I'm refreshing your information. Okay? So, renal artery goes from the aorta, from the descending abdominal aorta, goes to the kidney, enter the kidney, right? And it's going to branch as follows. And actually, the branches is something that you need to know. Okay? You need to know the branches. So, renal artery, we will see this. Renal artery is going to divide into segmental arteries, and then interlobar, arcuate, interlobular, and then afferent. Afferent bring the blood in. The blood goes in the glomerulus under hydrostatic pressure, pushing it out. Now understand this. When you push the blood out, part of the blood is going to leave. What is that part? The part that contain very small molecules. Something like water. Water is 2 H's and 1 oxygen, right? This is 3 atoms. This is very small. So water will leave. How about amino acid? Amino acid. Monosaccharide. Fatty acid. These 3 are the basic units of the organic molecules. Carbohydrates, fats, and proteins. Do you remember this? What's the building unit of protein? Amino acid, right? What's the building unit of carbohydrate? Monosaccharide. What's the building unit of fat or triglyceride? Fatty acid. So yes, this is small enough to pass through this. What else can pass? Any electrolyte can pass. Very tiny. Something like sodium, chloride, potassium, hydrogen. This is 1 atom, right? If amino acid, which is bigger than that, it can pass. So also electrolytes can pass. Any electrolyte. Sodium, potassium, calcium, hydrogen, HCO3 bicarb. All of these can pass through. Now anything that's bigger than this will not pass through. This is the basics. We need to know this, not just for questions, because we're going to build on it like we always do. Okay? So anything that's bigger than that will not go, cannot pass through. So it will stay in. It cannot be filtered out. What if it filtered out? What if it leaves the glomerulus? There is a problem with the glomerulus. Okay? This is exactly like this. This is the opening of the glomerulus. The pores are like this. Okay? Let's say this is amino acid, fatty acid, monosaccharide. This is the biggest thing that can go through. It can go like this, barely. Okay? So it can filter through. How about this? This is a protein. No. Right? How about a cell, which contain a lot of protein? Can it go through? Of course not. So what cannot leave? Protein, fats, carbohydrate, the polysaccharide, the big ones. How about cells? Of course not. Cells consist of protein, a lot of protein, and even one molecule of protein cannot go through. So how about the whole cell? Of course not. So protein cannot filter out and go to the urine. Cells, red blood cells, white blood cells, platelets, nothing, none of those. No proteins, no cells. What if I see something like that in the urine? I tell you immediately, there is a problem. These pores are broken, so this can leak out, right? Like if I ask you, I want you to bring your truck inside this classroom. Can you? Of course not, right? You can barely go. You are amino acid, fatty acids, monosaccharide, okay? Can you bring the truck in here? Of course not. What if I insisted? You break down the wall, right? If you can do it, I will tell you, the wall is broken. There is no other way for you to get the truck in here. So there is no other way to take the truck out, which is the protein or cells. You cannot, unless this is broken for one of the diseases that we will talk about. Is that clear so far? So we have glomerulus Bowman's capsule. Together you call it corpuscle, which is this. Out of the corpuscle, out of that, you will have, so we make, what the part that's leaving here is called the filtrate. You mean urine? No, I mean filtrate. Urine is different than filtrate? Of course, yes. Are we following? So what is filtered out of the glomerulus? It's filtrate. What's the difference between filtrate and urine? Urine is the end product that contain the bad stuff, not good stuff. The filtrate contain both of them. Let me give you an example. Here is everything that small will leave, right? It's not selective. Fatty acid goes out, amino acid goes out, glucose goes out, vitamins goes out, right? Potassium, sodium, hydrogen, everything goes out. Non-selective. This is bad, right? Of course, you don't want to get rid of your food, right? You don't want to get rid of your nutrients. So whatever will be filtered out is solely dependent on the size. Anything that's small enough will leave. It doesn't mean it's bad. It doesn't mean you don't need it. You will take it back. You will take it back. So what's leaving here is called the filtrate. And what's going to happen later is, out of this, you will have this tube, which is called the proximal convoluted tubule. Convoluted means folding like this. And this is closer, so you call it proximal convoluted tubule. And then you have a loop like this, which is called the loop of Fano. And then another convoluted tubule that's called the proximal convoluted tubule that will open to the collecting duct. So you still need to know this. And this part is called the tubular system. Proximal convoluted tubule. Proximal convoluted tubule. Loop of Henry. This is distal convoluted tubule. This is collecting duct. Okay? So by the time the filtrate, it's not urine, the filtrate is going through this, you are going to take what you need back to the circulation and secrete what you don't need out. So it's moving. Let me take back water. Of course, it's good. Let me take back glucose, fatty acid, nutrients in general. Let me take back my vitamins. Let me take back my bicarb, which is good. Okay, let me take back sodium. So it's going, take back the water, take back all what you need, until it goes to the collecting duct at the end. This is urine now. Why is it urine? Because you take everything that you need and you get rid of everything that you don't need. This is the final product. We'll go to this point here. Out of this is called urine now. This is the renal papilla. So from the renal papilla, which is the end of the collecting duct, urine, not going to change anymore. Final product. Urine is going to go to the minor calyx, major calyx, renal pelvis, ureter, bladder, urethra, outside when you urinate. Did you understand the concept? I summarized what we need to know. And this is called the corpuscle, which is two components, the glomerulus and the corpuscle. This is called the tubular system. Together, all this red, nephron. All the red is nephron, which is the functional unit of the kidney. And this is the blood supply just talked about. This is the interlobular afferent, and afferent is bringing the blood in. Afferent and efferent is out. To remember it, afferent with A is like accessing the corpuscle. Afferent, accessing, A. Efferent, exit, E. Efferent, exit. So what's entering is afferent. Go to the glomerulus. What's leaving is efferent. And then the efferent is going to make, around the tubules that we talked about, it will make peritubular capillaries surrounding all these tubules. So that if you need something back, you take it from the tubule to the peritubular capillaries back to the blood, which is reabsorption. If you want to secrete something, you take it from the peritubular capillaries to the tubular system. Did you understand what's happening here? Now the formation of urine. The filtrate will leave out of the glomerulus, as I mentioned, go to the Bowman's capsule, and then to the proximal convoluted tubule, to the distal, to the lobofilm, to the distal convoluted tubule, collecting duct, and this is for the filtrate. Okay. So, what is the sequence of filtrate? This can make a good question. What's the sequence of filtrate? Out of the glomerulus to the Bowman's capsule, to the proximal, to the lobe, to the distal, to the collecting duct. That's it, for the filtrate. If I ask you about the urine, which is different, the sequence of the urine is from the collecting duct, minor calyx, major calyx, vena, pelvis, ureter, bladder, urethra. Did you get this sequence? This is important to know, the sequence. Not just the names. 1, 2, 3, 4, 5, the sequence, okay? So here it is, the sequence of the filtrate, and always differentiate between filtrate and urine. It's completely different. Okay? So what is the filtrate contain? Contain all of this. Okay? What is this? Everything that's small. I talked about this, right? Anything that's small. Nutrients, electrolytes, water, waste products that are small. All of this is small enough to leave. Something like urea, ammonia, all of this will leave. Anything that's small will leave. If you want to remember it, remember what doesn't leave. That will make more sense. Cells and proteins doesn't leave. Too big. Remember it like this. This is the protein and these are the pores. Can you pass this through this? This is protein. It cannot go out. It should not. So remember this. Now what are you going to reabsorb? Take back. You're going to reabsorb all nutrients, all of them. You don't want to waste your nutrients. What's the reason for losing your nutrients? You want to take all your nutrients. If you have anything like vitamins or something, you take it back. You reabsorb it back. How about the water? 90-something% you take it back. Let me tell you this. Every 4 minutes, your entire blood circulates through the kidney. So how many times per hour does your blood circulate? 15 times per hour, which is 5 liters by 15, this is 75 liters. Multiply that for the whole day, literally, if you don't take your water back, you need a barrel of water. You need to take a barrel of water with you everywhere you go. And drink like 200 liters per day. Do you drink 200 liters per day? Of course not. Why? Thanks to reabsorption, that we take 90-something% back, you don't need to replace it. So how about the part that's lost in the urine? Is that water that you don't need? No, this is just the water to carry the dissolved elements. You cannot get rid of ammonia like this, ammonia by itself. It has to be carried on the water, right? So you reabsorb everything that's needed. And reabsorption means it goes from the tubules to the peritubular capillaries. Secretion from the peritubular capillaries to the tubules. What's the mechanism of absorption? There are different mechanisms depending on what we're reabsorbing, but I want you to remember water specifically. How do you reabsorb water? Like water will go from here, from these tubules to the peritubular capillaries. The question is how? By osmosis. What does that mean? It means the peritubular capillaries surrounding the tubules, they have more osmotic pressure, so water moves from the tubules to the peritubular capillaries. How does it move? Osmosis. There are other things like active transport and co-transport. It needs some energy, but osmosis for water is more important. Okay? Proximal convoluted tubule, you reabsorb all nutrients, all nutrients and most of the water in the proximal. This is summarizing what is going to be reabsorbed and secreted. The proximal convoluted tubule is all nutrients and most of the water and sodium. Loop of Fennel, this part is for the water, this part is for sodium chloride. So descending is for water, ascending is for sodium chloride. The distal convoluted tubule, this is where you take sodium back and get rid of potassium. Let me tell you this. Under normal circumstances, right now, you're sitting down, right? What's happening now is your metabolism that's happening inside the body produce a lot of hydrogen, okay? So under normal circumstances, unless something wrong happened, right now, you're trying always, your kidney is always trying to get rid of hydrogen. Can the kidney get rid of bicarb and reserve hydrogen? This is abnormal. But what happened in normal circumstances is all these metabolic reactions produce a lot of hydrogen. So you always have an overload of hydrogen under normal circumstances. You don't have a disease. You don't have a problem. This is normal. You produce hydrogen anyway because of the metabolism of your body. So produce hydrogen, and your kidney on a daily basis, every minute, every hour, is trying to get rid of hydrogen and potassium. This is normal. And you always try to take back bicarb and sodium. This is normal. Are we following? Under normal circumstances, your kidney try to get rid of hydrogen and potassium. Why? Because we always have excess of potassium. We always have excess of hydrogen and potassium. So usually your kidney try to get rid of it. How about the sodium and bicarb? This is something that's needed. We don't have enough most of the time. So this is under normal circumstances. Can that change? Can that rule change? It can, depending on the condition. Here is an example. I'm telling you that under normal circumstances you get rid of hydrogen, right? Okay, you get rid of hydrogen. What if you have a problem and you have alkalosis? Do you still get rid of hydrogen? So the alkalosis will become even worse? No. You can change it, but under abnormal circumstances. I was talking about the normal. Are we following so far? So where did you get the sodium? Here, proximal. Potassium and hydrogen is distal. Sodium here, potassium and hydrogen is here. How about the water? It's all over. We take it from all parts. Reabsorb water all over. If you remember that, that's good to remember. Now, let me go back to this. If you noticed here, aldosterone and ADH. Do you see this? Aldosterone and ADH. Do you remember this? I just talked about it, right? Angiotensin, angiotensin 2, ADH, and aldosterone. And I told you that ADH increased water reabsorption, right? From the kidney. Aldosterone increased sodium reabsorption in the kidney, right? Where? Here it is. This is aldosterone, and this is the ADH. Mainly the ADH work on the distal convoluted tubule and collecting duct, aldosterone on this part of the distal convoluted tubule. So mainly those hormones work on distal convoluted tubule, mainly. The ADH work on the collecting duct as well. Okay? So if you ask yourself, so let me see here. You reabsorb sodium? How much sodium? Who determine? Aldosterone. Aldosterone will tell you. If you have a lot of aldosterone, you reabsorb more sodium. Are we following so far? ADH. I told you that you reabsorb the water back, right? How much? How to know? How these tubules know? How much? What should I reabsorb 99% of the water, or 98 or 97 or what? It's 90 something anyway. But exactly how much? ADH will tell you. If you see more ADH, reabsorb more water because your blood pressure is going down. Okay? If your blood pressure is not going down, reabsorb less. In all cases, it's 90 something anyway. Do you have any questions so far? Everything's clear? Okay, so now what's the function of the ADH and aldosterone? This is something that's very important to remember. From the name, let me explain it this way. Always read the name, break it down, you'll understand it. And instead of just memorizing it as it is. What's anti? Against. What's diuresis? Diuresis. A lot of urine. This is against a lot of urine. Make sense? It prevents you from making a lot of urine. How? By taking the water back. Prevent diuresis by taking the water back. Aldosterone reabsorbs sodium. Okay? Reabsorb sodium back. You have to remember this. Here is one more hormone that we will talk about, which is the atrial natriuretic hormones. And all of these combined, ADH and aldosterone, we talked about this, right? Plus this one, which is the ANH, atrial natriuretic peptide or hormone. From the name, atrial means it is secreted from atrial. From the atrium, yes, from the heart. The heart secrete hormones, yes, just two of them. So this is something that's coming from the atrium. And read, natriuretic, what's nat? Natrium. Na. Sodium. Sodium. And what's uretic? Urine. So what's the translation? Sodium in the urine. Very simple. Yes. Just read it. Natriuretic. Natriuretic. Sodium in the urine. So what's the function? Throw sodium in the urine. This is exactly the opposite of what, if you're paying attention? The opposite of what? Natriuretic. Sodium in the urine. The opposite of what? Of which one of those?
Anti-diuretic.
Anti-diuretic hormone work on the water. I'm talking about sodium.
Aldosterone.
Aldosterone, what does it do? Sodium reabsorption. This is sodium secretion. It's the opposite, isn't it? Mm-hmm. Are we following? Are we following? Again, aldosterone, sodium reabsorption. Natriuretic, sodium secretion. This one, take the sodium back. This one, get rid of the sodium. Isn't that exactly the opposite? Reabsorb sodium meaning you take it back to the circulation. Secreting or getting rid of sodium meaning you throw it out in the urine. Isn't that exactly the opposite? So those two hormones work the opposite way. So which one should take the upper hand? Depending on your needs. Under normal circumstances, this one take the upper hand. So aldosterone and atrial natriuretic peptide, they're doing two opposing action. Like this. I appointed one of you guys to push the door out, to open it, and the other one will close it from outside. If I want the door open, I will give you the upper hand to open it, right? If I want the door closed, the one who's outside, take the upper hand and close it, right? So the aldosterone or atrial natriuretic peptide take the upper hand, it depends. Under normal circumstances, aldosterone take the upper hand. Okay? So these three hormones, if you notice, this is water, sodium, sodium, right? Water, sodium, sodium. So what is controlling the water and electrolytes? The three. ADH, aldosterone, atrial natriuretic peptide. So if I ask you which of the following control the reabsorption of water and electrolyte from the kidney? These three. If I'm asking about water, it's ADH. If I'm asking about electrolyte, aldosterone and atrial natriuretic hormone. Are we following so far? So remember that all of them, all three, control the water and electrolyte reabsorption. Now this is the blood pathway. I mentioned it. Renal artery to the interlobar, to the arcuate, to interlobular, to the afferent glomerulocapillaries, to the efferent peritubular capillaries, interlobular, and the other way around until you get to the renal vein. You have to know this sequence. So what are the sequences that you need to know so far? The sequence of filtrate, the sequence of urine, the sequence of blood. Did you get the three sequences? And because this is important, you can be asked about it. Now, what's the glomerular filtration rate? Glomerular filtration rate, read it. Do not just memorize. Let's understand. Glomerular filtration rate. The rate of filtration from the glomerulus, isn't it? Just reading it. So, what's the rate of filtration? How much do you filtrate? Okay? This will depend on the following. First of all, there is an autoregulation mechanism. Autoregulation. It regulates itself, basically. Okay, so what's the autoregulation? This is a regulation from inside that's controlling the filtration through the glomerular capillaries. Autoregulation. It regulates itself. What does it mean, regulate itself? Mean if there is too much filtrate, it will slow it down itself. Even without you telling it. It will delay. If it is less, it will increase. It auto-adjusts itself. This is auto-regulation. Did we get this part? By itself. It's regulating itself. Too much blood is coming to me. I need to, the filtration is too much. I will reduce it. If it is less, I will increase it. It's self-adjustment. Okay, this is called auto-regulation. Now, how exactly do you auto-regulate? Look at this. The afferent enter the blood into the glomerulus, right? And the efferent take the blood out of the glomerulus. This is exactly like the sink, kitchen sink, like the sink in your kitchen. Here is how it goes. Afferent is like the water tap. This is like the sink. Efferent is like the drainage. If I ask you to keep the water in the sink like half, okay? What do? The amount of water that's coming from the water tap is controlled. The amount of drainage is controlled, right? If I want you to fill the sink, open the water tap, right? And less drainage. If I want less water in the sink, do the opposite, right? So close the water tap a little bit and open the drainage. Does that make sense? So what do you do here? You're controlling the diameter of the afferent and efferent. So can you help me with this? Think about it. If I wanted to make more filtration, which one to dilate and which one to constrict? Can you think about it and tell me? I wanted to make more filtration, increase glomerular filtration rate. What should I do with afferent and efferent? Which one dilate and which one constrict? I want to make more. Constrict the efferent and? Exactly. Yes. So you open the water tap and less drainage, right? What if I want to do the opposite? I want to reduce the glomerular filtration rate. What should I do? Constrict the afferent and dilate the efferent. What are you doing by controlling this? More blood goes in, more hydrostatic pressure. Hydrostatic pressure. More hydrostatic pressure. More pressure pushing it out. Hydrostatic pressure specifically. Okay? If you do the opposite, less hydrostatic pressure. So when you dilate the afferent, constrict the efferent, more blood enter, higher hydrostatic pressure, pushing the filtrate out more, increased glomerular filtration rate. So the question is, how do you increase glomerular filtration rate? Dilate afferent and constrict the efferent so that the hydrostatic pressure inside the glomerulus increase, pushing more filtrate out, increasing glomerular filtration rate. Does that make sense? Anytime you have a question, raise your hand. It doesn't make sense to me. Just tell me whatever you want. Okay? If If you have a question or you disagree or something, let me know. So what are we doing here? Controlling the glomerular filtration rate. How? Hydrostatic pressure. How? Afferent and efferent diameter. Is that clear? So what's autoregulation? Autoregulation is a local minor reflex. It's a reflex that adjusts the diameter depending on the blood flow that's coming. Okay? So more blood flow is coming, it's going to reduce it. Less blood flow is coming, it's going to increase it, right? So this is called the autoregulation, auto-adjustment. It's a local minor reflex to adjust the diameter of the arterioles. Which one? Both of them. You adjust those two. Dilate, constrict, or constrict, dilate. Locally. Should something tell the glomerulus to do so? No, it happened by itself. And that's why it's called autoregulation. Regulate itself. I'm going to regulate myself. If a lot is coming to me, I'm going to decrease it. If less is coming to me, I'm going to increase it by playing with the diameter. Okay? Sympathetic nervous system. When sympathetic nervous system kicks in, take the upper hand, like you're fighting. You think you make more urine or less urine? Can you tell me? Less, right? You are in a fight. Is that a good time to make urine and go to the bathroom? Of course not. So what should you do now? What should you do with the diameters? Can you tell me? Sympathetic. Do you dilate afferent and constrict efferent, or the opposite? Do you want to make less urine or more urine? More urine, you go to the bathroom in the middle of the fight. Think about it this way. Give me a minute, go to the bathroom, come back. It's less, right? How to make less? Constrict what? Constrict the afferent and dilate what? The afferent. Less blood enter, less hydrostatic pressure, less filtrate, less urine. Make sense? Did you get this? How to play with the sympathetic. How about renin? Renin is secreted, I talked about it, it's right here. Secreted from the kidney. Which part of the kidney specifically? You need to know this. Juxtaglomerular cells. What are the juxtaglomerular cells? These are cells that are located here. Specifically here, look. This. Okay? In the afferent. Cells in the afferent that secretes renin. And I talked about the function of the renin already, which is called the renin-angiotensin mechanism. Okay? Now the composition of blood filtrate and urine. You don't need to remember these numbers, it's too much. Okay? But what you need to know is, look at the urine. Should you see cells? No. Under normal circumstances. I'm not talking about abnormalities now. Are you supposed to see glucose?
No.
Does it filter out of the glomerulus? Yes, but you take it all back. So you're not supposed to see, right? So glucose, nothing. Protein, are you supposed to see protein in the urine? It doesn't leave in the first place, right? Are you supposed to see cells?
No.
It doesn't leave in the first place. Do you remember this? You're not supposed to see it. So understand the normal about the urine and the filtrate, so when you see it abnormal, you know what we're talking about. So you're not supposed to see protein or cells in the filtrate or in the urine. It doesn't leave in the first place. Cells and proteins are too big. It doesn't leave in the first place. You don't see it in the filtrate or the urine. How about the nutrients like amino acid, monosaccharides, fatty acid? Are you supposed to see it in the filtrate? Why not? Monosaccharide, fatty acid, amino acid. Is that too big? No, it's small. You should see it in the filtrate, but should you see it in the urine? No. Why? Because you reabsorb. Yes. So yes, the answer is no, but why? Okay? Protein and cell, the rationale is obvious. It's too big. It will not leave in the first place. It doesn't leave the glomerulus. But for these Glucose, which is monosaccharide, fatty acid, amino acid, should it leave in the first place? Yes, it's small. But is it supposed to be lost in the urine? No, it's not. You should take it all back. And that's the importance of understanding the first part, which is anatomy and physiology. Now, incontinence and retention. Micturition reflex. If you printed the slides before last night, you're supposed to print it in the morning because they change a little bit. But anyway, what you see here is I added a little bit, I play with it a little bit. If something that I think is important that you can see, I add it to the slides. Okay? And so what's a micturition reflex to start with? What's a micturition reflex? Micturition reflex is when the urine accumulates in the bladder, right? Here is the bladder. And this is the urethra. Urine accumulates here. If it is half or more, the internal sphincter, which is this sphincter, is going to open because of the stretch. It doesn't mean you urinate. It doesn't mean you urinate because you have an external sphincter. Are we following? When the urine accumulates, the bladder distends and the internal sphincter open. Does that mean urine is leaking out? No, because automatically the external will close. Do we close it? No, it will occur automatically. What if you're sleeping, right? You're sleeping. And urine is accumulating in the bladder, so the bladder is distending and the internal open. You're not supposed to urinate while you're sleeping, right? How? Reflex automatically when the internal open, reflex nerve, then go to the external close. How do you urinate then? Voluntarily relax the external. So the external is voluntary. The internal is involuntary. And the in goes with the in. Internal, involuntary. Are we following? It will happen anyway. You have zero control over the internal one. You cannot close it. Okay? But you can't control the external. So what's the micturition reflex? Increase urine in the bladder, distending it so the internal open and the external close. What if you want to go to the bathroom? Relax the external and the urine will go out. What's enuresis? Or incontinence first? When you lose the voluntary control of the bladder, here's what's happening. Like this person is having a long-standing diabetes or have a problem with the nervous system or something, and here's what's happening. Urine accumulating in the bladder is distending, the internal open automatically, right? And the external is supposed to close, right? You have a problem in your nervous system. It doesn't close. So the internal open, the external open, leak out. So if there is a problem with the voluntary control of the bladder, this is called incontinence. Continence means control. Incontinence, no control over the urination. Enuresis is an involuntary urination of, if the child is age 4 or above. Do we know the potty training is supposed to be successful around the age of 4 to 5, right? If it is more than that, there is some sort of a problem, right? Sometimes it's delayed for other reasons, but this is the normal age, 4 to 5. If that does not develop in the normal age, this is called enuresis. Like the child is old child and he's still urinating in his bed, enuresis. Okay? And this is usually, most of the time, it is developmental delay, like this connections, the nerve connections between his bladder and the brain is not well established yet. Sometimes its sleep pattern is abnormal or psychosocial aspects, like some children have a problem like emotional trauma or a problem in their house or something, so they have enuresis for psychological problems. Okay? Stress incontinence, it's more in women. When the abdominal pressure increase, the urine can be lost. Overflow incontinence, if the bladder contain more than normal, it will overflow and start to leak. And this usually will mean a problem. Either this is an adult person or a problem with the spinal cord or the brain. Now urine retention. Urine retention is exactly the opposite of incontinence. It's the opposite. So you're trying to urinate, but you cannot. Is that clear? Retention, the opposite. You cannot empty your bladder. If you cannot empty your bladder, the bladder the urine accumulate, fill, and start to drop off, overflow. Okay? What's the reason for that? A lot of reasons. Maybe there's an obstruction or something of the pathway. Sometimes something like prostatic hyperplasia, for example. If there is a spinal cord injury at the sacral region, this is where we control the bladder. Anesthesia, sometimes after the anesthesia, if you ever heard about this person, a relative or a family member or something, and it happened a lot, if you notice that. He's doing a surgery, he got the anesthesia, everything is okay. After that, he tried to go to the bathroom, he cannot urinate. And sometimes they stay for some time and then return back to normal. And this is called retention. Now, diagnostic tests. Normal appearance of the urine is very important to know. Very important. Okay? What's a normal appearance and abnormal appearance? Very important. You have to memorize this. What's a normal appearance? The color should be amber yellow. Amber yellow. Not too dark, not too light. Amber yellow. Slightly yellow. It should be clear, not cloudy. Clear or cloudy have nothing to do with the color. Okay? It can be colorless and clear. It can be yellow and clear. Okay? So cloudy means it contains something suspended in the urine, which is not supposed to be. It should be clear. If you have something suspended, it means something is leaking out of the urine and come to the urine and be suspended. So if I take urine in the test tube and look at it, you'll see something suspended. This is called cloudy. And if that's the case, I tell you right away that there is something unusual. It's not supposed to be like that. Something like proteins. You're leaking proteins for some reason. You have infection, pus. Pus will be suspended. Okay? Bacteria. You have infection. Blood. Anything that's... Do you remember the big stuff that's not supposed to be there? Proteins and cells. If the big stuff is there, it will make it cloudy. Okay? Color should be amber yellow. What if it is dark? What does it mean? If it is dark, reddish, it can be hematuria or bilirubin. What's a bilirubin? Bilirubin. If you have a lot of bilirubin, something like hepatitis. Do you know that hepatitis people have dark urine and light colors too? Yes. So it can be a problem with that. So it can be blood, bilirubin, or, and this should be the first question to ask, highly concentrated urine. What does it mean? My urine is dark. First question, before jumping into conclusions, I should ask you, did you drink a lot? No, I didn't drink for the past 2 days. I drink a little bit of water. So it means your urine is very concentrated. So this is the first thing. If you're drinking normal, then I'm going to jump into blood or bilirubin. Okay? What if the blood is black? Black, not dark, black. What if it's too dark? Black. This means there are RBCs and proteins, both of them, in the urine. And this will mean one of the pathological conditions that we will talk about. But a combination of red blood cells and protein will make the urine black, and it will cause something called cast as well. Are we following? The presence of a combination of those two. Okay? Red blood cells plus proteins, both of them combined. This will make two problems. Number one, the urine will become black, very dark. Number two, they come together and make something called cast, urine cast. We will see it. The odor, it should be almost odorless. If there is a bad odor, it means there is a problem there. Or maybe you're taking medication. Here is a urine analysis. Do you see these bacilli here? So they can take a sample of the urine, put it under the microscope, and look if there is something unusual there. Are you supposed to see blood in the urine? What if you see blood, you call it Hematuria. You need to be familiar with these terms. Blood means, blood in the urine is? Hematuria. Protein in the blood is? Proteinuria. Glucose in the blood is? Glucosuria. Amino acid? Amino aciduria. Right? Okay, it's as simple as this. Amino acid and urea. Just add them together. Okay? Glucose, urea, glucosuria. Protein in the urine, proteinuria. Just add them. Blood in the urine, hematuria. Okay? Albumin. What's the albumin? It's one of the plasma proteins, isn't it? Plasma proteins. So if it appears in the urine, albuminuria. It's very simple. Just add urea to the name. You can make up all names. Okay? So what if you see proteinuria or albuminuria? Both of them are proteins, different types of proteins. It means that the albumin or plasma proteins are leaking out and appear in the filtrate. Is that something normal? Is the protein supposed to leave the glomerulus in the first place? No, what if it leaves? It means there's something wrong with the glomerulus, either broken or inflamed. Are we following so far? How about bacteria in the urine? Bacteriuria. You can make up all the names, trust me. Glucosuria, proteinuria, bacteriuria, hematuria, anything urea. Put urea beside anything, it will make sense. And if you see bacteriuria, it means there is infection of the urinary tract infection. Proteinuria means protein is leaking. Why protein is leaking? A problem in the glomerulus. The pores are getting too big or broken, maybe inflamed, maybe broken. Urine cast. Urine cast, if you see, what urine cast means, you see something deposits. Urine cast will tell you that there is inflammation of the tubules. By the way, every single word here is important. Every single word. When I tell you urine cast, you tell me right away there's inflammation. When I tell you proteinuria, you know immediately that there is inflammation of the glomerulus or the glomerulus is broken down. Okay? Specific gravity, which is how concentrated the urine is. Is it highly concentrated or low concentrated? It's supposed to be the normal concentration, okay? Irrespective of the numbers. Just remember the normal, it should be, the specific gravity should be within the normal range. What if it is getting low or high? Low means the urine is too diluted, right? If the specific gravity goes down, it means it's diluted. If it goes up, it means it's concentrated. Why diluted and why concentrated? It depends on the condition. Diluted means a lot of water is coming, right? Concentrated, less water is coming. Whatever the reason is, we will talk about it. What if you see glucose and keto? Are you supposed to see glucose in the urine?
No.
Glucosuria. What if you see it? Diabetes. This is one of the ways to diagnose diabetes. Glucose and also sometimes ketone bodies in the urine. Here is a red blood cell cast. Cast means aggregation. Red blood cells with proteins, they come together to make the cast. Now blood test. So if you have a problem with the kidney, what should we do? I should do urine analysis first. And according to the urine analysis, I can suspect. What else? We can study the blood. Take a blood sample and tell me what's happening there. You are going to measure the urea and creatinine. What's urea and creatinine? These are organic waste products. Do you remember the first slide when we talked about the functions of the kidney? One of them was to get rid of the organic waste products, right? Now here is the name that you have to remember: urea and creatinine. Urea and creatinine. What's urea and creatinine? These are organic waste products that should be secreted, or you should get rid of it in the urine. So if you see it elevated in the serum, it means the kidney is not getting rid of it, right? Are we following? Urea and creatinine supposed to be in the urine. You get rid of it in the urine. If it increases in the serum, it means you're not getting rid of it in the urine. Make sense? So you're not doing the job. There is a problem with the kidney, right? These are nitrogenous waste products, both of them, urea and creatinine, and I want you to remember the names specifically. These are nitrogenous organic waste products. Nitrogenous organic waste products. These waste products, creatinine and urea, nitrogenous organic waste products. You should get rid of it. It should not accumulate in the serum. If it accumulates in the serum, you're not doing the job. The kidney is not doing the job. It should get rid of it. And it basically means, the first thing is decreased glomerular filtration rate for some reason. Here's the glomerular filtration rate. Do you remember this? So what's happening here is it doesn't leave in the first place. It doesn't leave. Glomerular filtration rate is going down. Another thing is metabolic acidosis. Metabolic acidosis also means decreased glomerular filtration rate. Why? Think about it this way. Glomerular filtration, what should be filtered out? Good stuff and bad stuff, right? Good stuff and bad stuff. What's the bad stuff? Organic waste products. And also, remember, you're supposed to get rid of hydrogen. I told you under normal circumstances, you have a lot of hydrogen and potassium that you should get rid of, right? If you're not getting rid of it, if you're not getting rid of hydrogen, hydrogen accumulates in the blood, which is acidosis, right? So, anytime glomerular filtration rate goes down, you don't get rid of what you're supposed to get rid of. Are we following? If the glomerular filtration rate is okay, everything is fine. Get rid of organic waste products, you get rid of hydrogen, you get rid of potassium. If the glomerular filtration rate goes down for some reason, like hypotension for example, whatever the reason is, you don't get rid of what you're supposed to get rid of, right? Accumulating in the blood. So glomerular filtration rate is the first thing that you always think about, whether for increase these nitrogenous organic waste products or metabolic acidosis. Anemia. What if you have anemia? What does it tell us for the kidney? Is anemia related to the kidney? It might be related to the kidney. Why? Maybe the kidney does not secrete erythropoietin enough. Do you remember the first couple of slides when I told you it's important? Do you remember the fact? It's right here still. Renin and erythropoietin, right? Erythropoietin to increase red blood cells. What if you have a disease in your kidney and you're not secreting erythropoietin? Do you get anemia? Yes. But does that mean when I see anemia, I'll tell you that you have a kidney problem? Of course not. Right? When I see anemia, I think about it. Maybe one of the reasons is the kidney. Maybe you're not secreting erythropoietin, but it may be something else. So it should be combined. So you have anemia, I don't know what it is. It might be. But you also have metabolic acidosis, so more suspicious. And you also have elevated, now, if you combine those, so the kidney is not doing the job, right? It's not an isolated thing. And for each one of those, you need to know why. So the first one, the first two are related to decreased glomerular filtration rate. And this is the first thing that happened to the kidney if it is failing. And we will talk about renal failure later on. Are we following? Decreased glomerular filtration rate can mean a lot of things, including early stages of failure. Anemia is because of erythropoietin. Electrolytes. You can measure the electrolytes in the serum, and it depends on the condition. You don't know exactly. Antibody level. There are two antibodies. This is abbreviated ASO, anti-streptolysin O. ASO, this is abbreviation, if you heard about ASO before, anti-streptolysin O, and anti-streptokinase, which is the ASK, this is the abbreviation. So ASO and ASK. What is this? These are antibodies against streptococcal infection. So if I see it, I'll tell you, you have streptococcal infection, which is called the streptococcal glomerulonephritis. We will talk about it, but understand it from now. Okay? If the renin level is increased, Renin increased. What's the action of renin? The end result, which is here. If you secrete more renin, what happened at the end? Plus, plus. So all of those will do what at the end?
Increase blood pressure.
Yes, increased blood pressure. So renin, at the end, it increased blood pressure. Via all these steps, I know, I understand that. But what's the end is hypertension, right? Hypertension. So if the renin increase and you're having hypertension, I tell you that you're having hypertension because of a kidney disease secreting too much renin. Okay? It can be one of the reasons of hypertension. You can also do other tests like culture sensitivity. And culture sensitivity is exactly like this. I'm suspecting that you have infection, okay? I can give you like antibiotic, something general, broad spectrum or something. If that doesn't work out, I will tell you, okay, I need a urine sample now. It's not working good. Give me a urine sample. I take the urine sample, culture part of it on a petri dish or something, and get the nutrients that the bacteria need to grow, and then try antibiotics, and I will tell you exactly, you need erythromycin, for example. You need penicillin. So I know exactly which antibiotic if the broad spectrum is not working. A radiologic test, there are a lot of things that can be used, MRI, CT, and others. Scope, whatever the type of scope is. You can take biopsy, you can use the clearance test. The clearance test is you test how much the kidney is able to clear creatinine and inulin. You can also do cystoscopy. Cystoscopy means you introduce endoscope into the bladder if you're suspecting something like stone or cancer or something. Now what's diuresis means again? I mentioned it like a few minutes ago, diuresis. A lot of urine. So what are the diuretic drugs? Drugs that induce a lot of urine, right? Are we following? Diuretic drugs. Drugs that induce diuresis. So it make you make more urine, right? Why do you think you need diuretics for? Or let me think about it this way. I give you diuretic as a treatment. You're going to make more urine, right? Diuretic, a lot of urine, right? So when you make a lot of urine, you get rid of a lot of water, right? What happened to the blood volume? Decrease or increase? When you get rid of a lot of water, you take the water from the blood, throw it in the urine. What happened to the blood volume? Decrease. What happened to the blood pressure? Decrease. So what do we use the diuretics for? To decrease blood pressure if you have?
High blood.
Yes, which is?
Hypertension.
Hypertension, yes. So diuretics is the treatment for hypertension, isn't it?
Yeah.
Yeah. So diuretics, how does the diuretics work? Get rid of a lot of water. How? You get rid of sodium, followed by chloride, followed by water. Do you remember when I mentioned that in the beginning? Sodium, followed by chloride, which is just shadow, followed by water. Do you remember this sequence? This is how aldosterone works, right? Diuretics is the opposite of aldosterone, okay? Diuretics, a lot of urine. How do you do that? Get rid of sodium. Drop or decrease sodium reabsorption, which is the opposite of aldosterone. Are we following? When you get rid of sodium, followed by chloride, followed by what? Water, yes. So you make a lot of urine, right? Pay attention to the end. These are for the diuretics. There are a lot of diuretics that will be too much to ask. But just remember, this is the most famous one, so just remember this will be fine. Do you guys know the Lasix? I think it's very famous. This is furosemide, okay? So this is one of the diuretics. Whatever the diuretic is, this is pharmacology, too much. Let me say it this way, just to save you some time. Treatment is not very important here, in this course, okay? You can, unless there is something specific, I will tell you, okay? But don't waste a lot of time in the treatment. It's not the most important. Pathophysiology is more about the pathogenesis and the signs and symptoms, not the treatment. Now dialysis. Here is what I want you to know about dialysis. You can read if you want to, but I'm just saving your time, okay? Giving you what's the core of this, what's the most important. Dialysis is, somebody's having a problem with his kidney. The kidney is failing, not just any problem. To the extent of failing, the kidney is failing to do the job. What should we do now? 1 out of 2. You tell me first. You're coming to the dialysis unit and I need dialysis. Why do you need dialysis? Because my kidney is failing. Can you tell me if that acute failure or chronic failure? It makes a difference. Acute failure means it's failing right now. So this means that I will do dialysis temporarily until you regain. If this is chronic or end stage, means your kidney is destroyed. It's bad. It's not going to fix again. If it is acute, it can regain the function. If it is end stage, at the end, renal failure, it means it's not coming back. So you will have dialysis for life until you have a kidney transplant. Okay? Now, what dialysis is going to replace with the kidney functions? Which kidney functions will be replaced by dialysis? Filtration, reabsorption, secretion. Yes? Not osmosis. Not osmosis. Do you know the osmosis, water goes back? The dialysis doesn't have this property. You cannot do osmosis. Do you remember the osmosis? Mm-hmm. Osmosis help in reabsorption of what? Water. So you will find another way to get the water back, but it does not do osmosis. It can do filtration, reabsorption, but you cannot do osmosis. There are 2 ways, either hemodialysis and peritoneal dialysis. Hemodialysis is, hemo means blood. So here's how it goes. They put a catheter or a cannula from the artery, so the blood is leaving, enter the machine, it works like the kidney, goes inside, so as it is going like the tubules, okay? It will take this out, filtrate, reabsorb, filtrate, reabsorb. At the end, it will come back to the vein. Out, in. So both of those are to the blood vessels, right? Hemodialysis. The alternative is, they can use your peritoneum, the peritoneum membrane, they can use it as a filter. Okay, so they make the blood pass through the peritoneum and come from the other side, and it will make a good part of this job. Okay? So this is what basically the core of this part, and this is what you need to know. Okay? So the most important is, we have 2 types, hemodialysis, peritoneal dialysis. Hemodialysis, take the blood out from the artery and bring it back through the vein. What's the problem with that? You can do reabsorption, you can do filtration, you cannot do osmosis. The other one is peritoneal dialysis, using the peritoneal cavity for dialysis. Should you use the dialysis temporarily or until you replace the kidney? It depends. Until you replace the kidney, if this is an end stage, meaning the kidney is completely bad. But what if it's acute failure? Are you going to use dialysis forever? No. You use it temporarily until your body fixes itself, until the kidney fixes itself, right? Can the kidney fix itself? Of course, yes. If it is acute. So this is basically dialysis. Okay, you are doing the same as the kidney doing, but through a machine. Are we following? Whatever your kidney was doing, the machine will do it except osmosis. And this will be, read it if you want to. If you want to read more about the dialysis, but I give you what's related to us, okay? Now, disorders of the urinary system. Number 1, infection. Infection of what? Of anything. You can have infection of the kidney, you can have infection of the ureter, bladder, urethra. Okay? If it is infection of, is it infection of the upper urinary tract or lower urinary tract? If it is upper urinary tract, the upper urinary tract is kidney and ureter. Lower is the bladder and urethra. Are we following? Urinary tract is two parts, upper and lower. Okay? Upper, kidney and ureter. Lower, bladder and urethra. If it is lower bladder infection is called cystitis. Are we following? Bladder infection is called cystitis. Okay? Infection of the urethra is called urethritis. Just add itis at the end. If this is upper, meaning the kidney and the ureter, you call it pyelonephritis. The most common causative organism is, that you need to remember, E. coli. Okay? Look at all these bacteria. Look. Which one that you have to remember? E. coli. Okay? Did you get the importance of the lecture? Yes. It's not a list that you need to memorize, just memorizing like this. No. You need to be specific. What is the most common? All of these, yes, I understand there are a lot of infectious organisms, but the most common is E. coli. E. coli. Yes, all of these can cause it, but E. coli is the most frequent. Now, who gets more infection, males or females?
Females.
Why?
The ureter is shorter.
Wow, that's good. Ureter is too short, but this is not the only reason. Not the ureter, by the way.
Urethra.
Urethra. What's the other reason?
So close proximity to each other.
Yes.
Close proximity to
Urethral, the opening of the urethra in female, it's not just because the urethra is short. It's because the opening of the urethra is very close to the bacteria surrounding this area, close to the anus, close to the other structures. It's very close. Unlike males, it's far away. Okay? So two anatomical differences between males and females that make females more vulnerable. Okay? This is generally speaking between male and females. What's the difference between male, old, and young? What's the difference with age? What happened with age that make the urinary tract infection more frequent? So urinary tract infection, generally speaking, is more frequent in females if compared to males. How about the age? Older people get more. Why? Prostatic hypertrophy. What's a prostatic hypertrophy? This is a normal process. Most of elderly people, males, they get prostatic hypertrophy or hyperplasia. Hypertrophy means hypertrophy. Hyper means a lot, right? Trophy means size. So hypertrophy, the size increase. Okay? What's the problem with that? Look at this. If you guys still remember the anatomy, the prostatic urethra goes like this within the prostate, right? It passes through, penetrate the prostate, right? So if the prostate is hypertrophied, it's going to constrict the urethra, make the urethral lumen smaller, right? It's going to push on it, constrict it, so that the urine doesn't leave the way it should leave, accumulate, irritate, infection. So prostatic hypertrophy followed by urine retention. Why? Prostatic hyperplasia goes like this, or hypertrophy, hypertrophied, closing, not completely closing, just make it narrower, make the urethra narrower. So now the urine is not that easy to leave. If the urine accumulate, you're giving the bacteria the chance to multiply and make infection. Did we get this part? Some congenital, how about the children? Can the children have more chances of urinary tract infection? Sometimes. Okay? So we talked about females versus males, old age in males versus younger age. Now how about children? Children can sometimes get more cystitis because of something called vesico-urethral reflex. This is a congenital problem that we will see later on again, but let's understand it. What vesico means? Vesicle, which is referring to the bladder. Vesicle is a bladder. Urethral means? Urethral, not urethral. Urethral. Ureter. Okay, look at this. The ureter goes like this, right? The ureter goes to the bladder, right? And there is a slit-like opening here that the urine goes in and it doesn't go back. If it does go back, This is vesico-ureteral reflex. So the urine goes like this and then return back. This is a congenital anomaly. It's supposed to be like this. This is the ureter entering to the bladder, and you're supposed to have muscles that go like this. Close it. So making it like a one-way valve. Urine goes in, but it doesn't go back to the ureter, right? If it does, vesico-ureteral reflex, which is a congenital abnormality. Other causes: incontinence, retention, communication, contamination with the fecal material somehow, like a fistula or something like that. Now, what do you call infection of the bladder? Cystitis. What do you call infection of the urethra? Urethritis. What do you feel if you have cystitis? Infection of the urinary bladder. Pain here, right? Pain, where is your bladder? It's in the middle, right? So you feel some pain around this area. And also dysuria, urgency, frequency, and nocturia. What does it mean? What's this? DYS? Difficult. Dysuria means difficult urination. Urgency means urgency. I have to go right now. Emergency. You have to go right now, right? This is not normal. It means you have infection that's irritating your bladder, so I have to go right now. You have infection. Frequency. You go more frequency. Why? Irritation. Nocturia. What's nocturia? What's noct?
At night.
Night. So you wake up at night several times to go to the bathroom. There are also general signs, which is not the most important. Usually general signs is the same for everything. It doesn't tell you something specifically. Something like fever and malaise and headache and, leukocytosis, all these things. Now, if you see the urine, take a urine sample with cystitis or urethritis, the urine sample should be abnormal. Should it be cloudy or clear?
Cloudy.
If it's abnormal.
The abnormal, what kind of abnormality here in cystitis? What's cystitis?
Infection.
Infection of the bladder. Infection means what? Bacteria. So you have bacteria in the urine. Do you remember when we did the normal appearance of the urine? If you don't have any one of the big things, it's not cloud, right? So now it will be cloudy. Why? Bacteria. If you have any bacteria, cells, protein, it will be cloudy. That's why we did it in the beginning. Okay? Now I can take urine and not just looking at the urine. By looking at the urine, I can tell you that you have infection. Okay? Give me a sample of urine. Without analysis, I take a look at it like this. I put it in a test tube, and I look at it. Okay, it's turbid. So it looks like you have infection. Okay? Odor, if there is a bad odor, it means there is infection. But you still need to do the urine analysis. Put a drop on a slide and take a look at it and see. You will see some bacteria, which is called bacteriuria. And what's the pyuria? Does anybody know what it means? Pus in the urine. You'll see pus in the urine. Sometimes hematuria. Blood in the urine. Pyelonephritis. Pyelonephritis. What's a pyelonephritis? Pyelonephritis. Pyelo means ureter. Nephro means kidney. Pyelonephritis, infection of the kidney and the ureter, which is the upper urinary tract infection, right? So we did the lower, now this is the upper. Is it in one kidney or both of them? It can happen either way. It can come to one or two. Okay? What is the most frequent or the most common cause? Which bacteria? E. coli. Yes, there is a huge list. But what's the most common? It's E. coli. Okay? Sometimes people having prostatitis, they can have pyelonephritis, and here's why. This is a male. What do you have here? What is this?
Prostate.
The prostate, right? If this man having prostatitis, there is a continuation here, right? Do we know that the prostate open? There is a duct from the prostate that goes to the urethra. So if infection is here, it can leak out because of the continuation and go up. Do you understand why prostatitis leads to pyelonephritis? Okay, because of the continuation between the prostate and the urethra, and it goes up, pyelonephritis. Okay? If this is pyelonephritis, this is infection. So obviously, infection of what again? And ureter, right? So kidney and ureter. In the kidney, the renal pelvis will be like this. This should contain a purulent oxidate in the pelvis and the calyces. What's purulent mean? Pus. Yes. In cases of recurrent chronic infection, what if pyelonephritis happen and go, and happen again and stay frequently, time after time after time? What will happen? That's going to destroy the kidney itself, okay? Which is destruction of the kidney, necrosis, that will lead to scar tissue. The scar tissue is fibrosis, basically. The tubules will lose their function, and we know the function of the tubule, we did it in the beginning, reabsorption and secretion, right? You lose the function. It can lead to obstruction. Why? Fibrosis. Fibrosis goes like this. The fibrous tissue is kind of like a rubber band or something. It constricts anything. So it can lead to obstruction of anything. Hydronephrosis. What's hydronephrosis? What's hydro? Water. But here we mean urine. Okay? Urine is mainly water, right? So hydronephrosis is accumulation of urine in the kidney. Which part of the kidney? The pelvis and the calyces. Okay? Hydronephrosis. Why hydronephrosis occur? Because of obstruction. If obstruction happened here, let's say. Okay? Obstruction happened here. You still make urine, right? The urine is going down. And there's an obstruction here. It accumulates. Distending hydronephrosis. And what do you call the presence of a lot of urine in the ureter? Can you make up a name? Accumulation of urine in the kidney is hydronephrosis. What's accumulation of urine in the ureter? Hydroureter. Hydroureter. Just be simple. Take it simple. You can make up the name. It's hydroureter, hydronephrosis, or hydroureter. And most of the time, it's both of them. Hydronephrosis and hydroureter. Okay? If that happened enough to destroy the kidney itself, this is chronic renal failure. Acute or chronic? Do you need to know specifically? Yes. Chronic, not acute. Pyelonephritis cause acute or chronic renal failure. If it's at the end, chronic. Why? What's the difference? Acute means something that is severe enough, that's happened acutely all of a sudden, destroying the kidney. Okay? Like you take something that's toxic, nephrotoxic for example. Injury, all of a sudden. You have an accident that destroyed your kidney all of a sudden. This is acute, right? But pyelonephritis, is this something acute? Like it happened time after time after time, gradual destruction of the kidney tissue. So this is acute or chronic. You need to, by the way, acute and chronic renal failure is very important subject. Okay? So we didn't do it yet, but we are taking part of it as we go. So pyelonephritis cause chronic renal failure. Why? Because it's a gradual process. You have infection now, and then you have infection again, and then you have chronic infection. It takes months or years, gradually destroying the kidney tissues until the kidney fails. Okay? What should you feel if you have pyelonephritis, if the kidney is infected? Flank area, flank pain. What's a flank pain? You know where is your flank? This. This is called the flank. Do you know the floating reps? 11 and 12? Yeah, this area is called the flank. So you'll have flank pain, pain here. What is the reason for flank pain? You need to know this. It's because of infection, but what's the process? Why do you have pain? Here it is. Are what?
Never mind.
No, it's okay.
Are your kidneys there? So isn't that why with your lower
Yes, this is why you have a flank pain and you have pain here. But the question is, what is the process that created the pain? Why do you have pain in the first place?
Build up of, filtrate.
Inflammation, infection, yes, leading to what?
Stretching of the renal capsule.
Yes. Stretching of the renal capsule, did you read it? Okay. Do you remember the renal capsule from outside? Yes, this renal capsule contains a lot of nerves. So if infection occurs and it's going to stretching, you stretch anything, you get pain. Okay? So stretching of the renal capsule. In this case, urine analysis is not different from cystitis. Do you remember urine analysis with cystitis?
Inflammation.
Which is infection or inflammation of the bladder, and you see bacteriuria, and you see purulent discharge, and you see turbid, cloudy, and all that stuff. It's exactly the same. So this is not good enough to tell. Urine analysis is not good enough to tell. Urine analysis of cystitis and pyelonephritis is mainly the same. Right? Would the urine be smells bad? Yes, both of them. Would the urine contain bacteria? Both of them. Would it be cloudy? Both of them. So how to differentiate now? Cast, urine cast. This is something that's unique for pyelonephritis. Did you get my idea? So let me say it this way. Here is what I'm trying to emphasize. If you memorize everything as it is, you confuse between those two, right? Let me memorize pyelonephritis. Bacteriuria, cloudy urine, urine smells bad. How about cystitis? Same thing. How to know then? You focus on what's unique or what's the most common. Did you get how to study this? How to do good in this course? It's all about what's unique and what's the most common. What's unique and what's most common. What's unique here? Urine cast. When you see urine cast, that's it. You can't say it's cystitis. No urine cast with cystitis. But anything else? Not much different. And what's the reason for urine cast? Urine cast means the renal tubules are involved. Do you have renal tubules in your bladder? Where is the tubules? Tubules. In the kidney. It's part of the nephron in the kidney, right? So urine cast translation equals something with the tubules. Tubules in the kidney, unique, that's it. Not cystitis. Of course, any infection will be treated by antibacterial, and this is not something specific, and I mentioned before, treatment is not the most important thing. Now, inflammatory disorders, glomerulonephritis. Glomerulonephritis. What's itis means? Inflammation. So this is inflammation of the kidney, including the glomeruli, right? Mm-hmm. The most common that we need to know is acute post-streptococcal glomerulonephritis. Acute, meaning something happening acute. You will see it. Here is the anti-streptococcal. Okay, so you will see it. Acute post-streptococcal glomerulonephritis. Glomerulonephritis is here. Okay, what did we add it? Post-streptococcal. What does that mean? Post-streptococcal. Like this person is having streptococcal infection somewhere. Let's say here. Streptococcal infection somewhere. Strep, you know the strep throat, right? So you have a streptococcal infection somewhere. And then your antibodies are fighting it. Sometimes this complex, antigen-antibody complex, goes until it's settled in the kidney itself, starting a reaction, inflammation of the kidney. And this is called acute post-streptococcal glomerulonephritis. It's a type of glomerulonephritis that's follow streptococcal infection. Does it mean it's infection? No, it's not infection. Are we following? It's infection somewhere else. It's not infection of the kidney. It's infection somewhere else by streptococcus. Okay? So I have streptococcus somewhere, causing infection somewhere. Antibodies come with it. Those moves down, go to the blood, go to the urine, and go to the blood and go to the kidney and put itself on the glomeruli and the tubules, starting an immune response, causing inflammation. So it's not direct invasion by the streptococci. And that's why I didn't call it streptococcal glomerulonephritis. I call it post-streptococcal. Did you get the difference? So post-streptococcal glomerulonephritis is an immune process. And specifically, it's type 2 hypersensitivity. Type 2. Do we need to know that? Yes. So what's happening here? Immune response. Type 2. Type 2 immune response. Okay?
Why does it say
Type 3.
Type 3. Oh, I'm sorry. Type 3. Not 2. Sorry. Take it back. Type 3. Type 3 hypersensitivity reaction. It's immune complex. What's immune complex? The antigen that's coming from the streptococcus, antibodies comes against it. This is called immune complex. Do you get what's the immune complex? Antigen, antibody. Complex. This complex move down the blood, go to the kidney, start the inflammation process, and this is what it is. So what happened when this inflammation occur? It's going to increase here. It's going to increase inflammation. Do you remember when I mentioned inflammation of the glomeruli? Do you guys remember this? Do you remember when I said everything that's small enough will go anyway, and everything that's big enough will not go? And what was the exception? It's if the glomerulus itself is inflamed. Did I mention that? Right? Remember in the beginning when I said, are you supposed to see proteins in the urine? No. What if you see protein? What does it mean?
Tubules, too big.
The glomeruli, not the tubules, the glomeruli. Remember this? Look. This is anything that's small. Water, amino acid, glucose, anything that's small, right? And this is the pores. You go through it like this, right? This is protein. Can the protein go through it? It doesn't go through it. Except if the glomerulus is inflamed, the pores will be too big, protein will go. Did you get this point? So when does the protein leave? Glomerulus is inflamed or broken. Either inflamed so the pores are too big, or broken. Remember this box. This is protein, okay? Just remember it. This cannot go through this, except if this is too big, okay? Protein doesn't go through the glomerulus, except if it's inflamed, too big, go through it. Or if the glomerulus is broken down. Here it's inflamed. So does the protein goes?
Yes.
Yes, protein goes. How about other cells?
Yes.
Yes, anything can go. Isn't it big enough? So all the big stuff will go, right? And will start to show up in the urine, and this is glomerulonephritis. Did we get this process? Did you understand this? If the inflammation is too severe, there will be some sort of congestion and cell proliferation, and that will decrease glomerular filtration rate. So glomerular filtration rate decrease in glomerulonephritis if it is severe. Are we following?
Yes.
So what you're going to see anyway, the big stuff appears in the urine, okay? The big stuff, what's the big stuff? Albuminuria, proteinuria, hematuria, pyuria, anything appears in the urine, bacteriuria. The big stuff will appear because of the increased capillary permeability. If it is severe enough, there will be congestion and cellular proliferation, and glomerular filtration rate is going to decrease. Remember this glomerular filtration rate? If it decreases, it means the stuff will stay in the blood, right? Do you get rid of the waste products that much if the glomerular filtration rate decrease?
No.
You do not. Are we following? I want you to understand this. Okay? You will memorize it anyway, but understand it first. Are we following? If the inflammation is severe, this will lead to proliferation of the cells and congestion. And this will decrease the glomerular filtration rate. If you decrease the glomerular filtration rate, means you make less filtrate. Make sense? When you make less filtrate, it means you do not get rid of all what you need to get rid of, right? What should I get rid of? This will bring us back to the function of the kidney. The first slide. Aren't you supposed to get rid of the nitrogenous organic waste products? Urea, creatinine, ammonia, right? You're supposed to get rid of that. So what can happen in this case? It will accumulate. It will accumulate. And when the glomerular filtration rate decreases, do you make more urine or less urine?
Less.
Less urine. What do you call less urine? Oliguria. What is it?
It won't be hypourine? You can use that?
It's oligo, not hypo. No, hypo can.
Oligo?
Oligo. Yeah.
Yeah.
Oligo is this. Oligo or olig means less. What's the opposite of oligo? Poly. So when you make a lot of urine, it's called polyuria. When you make less urine, it's called oliguria. So which one show up here? Oliguria, because of the decreased glomerular filtration rate. Oliguria, less urine. Oligo means less. Poly means a lot. It's not hyper and hypo. It's oligo and poly. What should you see in the blood? ASO and ASK. We talked about this. Remember when we talked about the urine? ASO and ASK? What is that? ASO is anti-streptolysin antibodies and ASK is anti-streptokinase. ASO and ASK. Okay? This will be present in the blood. I take a blood sample from you and I see ASO, ASK. Why? So I know right away that you have streptococcal infection, right? And this was the cause for this. So ASO is because of the formation of, this is the antibody that I talked about. Remember the immune complex? Antigen, antibody complex, go to the kidney, right? What's the antibody? This, ASO, okay? So it goes to the kidney starting starting the inflammation process and causing the increase of ASO and ASK. Okay. Now with glomerulonephritis, still talking about it. The urine become dark and cloudy. What will happen to the urine? When I see the urine, what happened to it? The urine will be cloudy, right? Urine will be cloudy. Why? Bacteria, proteins, the big stuff will show up, make it cloudy, right? Protein, proteinuria, hematuria, and all that stuff. But remember that the blood here can be black. Do you remember when I mentioned the black blood? A combination of what and what? Red blood cells and, no, something else in the urine. I mentioned two things combined will make the urine black. And I told you to remember this. Protein, yes. Red blood cells and proteins combined will make the urine black. And what else? It will make two things. Cast, yes. So the presence of protein and blood and red blood cells combined in the urine will cause the urine to become black and causing cast. Okay? So black and make cast. What happened to the blood pressure? Hypertension. Can you tell me why? Why do you have everything is understanding. Here is why. What did I mention about the glomerular filtration rate? Increase or decrease?
Decrease.
Decrease, right? So less blood is going through. Do you remember the autoregulation? Right? So by autoregulation, these cells are going to secrete renin, increasing blood pressure. Did you understand this process? So why do we have hypertension? Renin. Less blood moving inside the glomerulus will lead to renin, increase and increasing blood pressure. The pain, again, it's the same thing because of stretching of the capsule. Oliguria is because of decreased glomerular filtration rate, and the other thing is you started to have some inflammation of the tubules and necrosis of the tubules. There are a lot of things that can tell you that this patient is having glomerulonephritis. Increasing serum urea and creatinine level. Aren't you supposed to get rid of those? Isn't that the organic waste products that we talked about? Nitrogenous organic waste products? You're supposed to get rid of it. If you don't get rid of it, start to accumulate in the serum. So this is the first thing that you're going to see. Give me a blood sample and let me know how much urea and creatinine do you have in the blood. I'll tell you if the kidney is doing a good job or not. If it increases, it's doing a bad job. Increase ASO and ASK. There are other things, but this is the most important. ASO, ASK. ASO and ASK. Those two are going to appear. What else is going to happen in that case? So we talked about hypertension will occur, right? Because of congestion and decreased glomerular filtration rate and ischemia. Renin, hypertension is due to renin secretion. Okay, what else is going to happen? Metabolic acidosis. So this is a problem that will happen with glomerulonephritis. Why? Why do you have metabolic acidosis? Yes, exactly. What's the normal function of the kidney? Under normal circumstances, what you're supposed to get rid of?
Hydrogen.
Hydrogen and potassium, right? You're supposed to get rid of them. So you're not getting rid of them. You're not doing the function, right? You don't get rid of them. Hydrogen accumulates, and you call this metabolic acidosis. So metabolic acidosis is because the tubules fail to do the exchange. Fails to do the exchange. It's supposed to get rid of hydrogen and take back bicarb. Isn't that the normal? Are we following so far? Don't start to doze or something. You have to stay concentrating until the end. Okay? The more you understand in class, the less effort you do. Okay? So what is the normal function of the kidney? You're supposed to get rid of hydrogen, potassium, and retain bicarb and sodium. Don't ever forget this. Are we following? What's the normal? Get rid of
Hydrogen.
and potassium. Retain
Bicarb.
and sodium. Can that change? Yes. If the condition permits, if there is a problem that you need to fix. But metabolic acidosis, because of this impairment of the tubular exchange, the tubules are supposed to get rid of hydrogen and take back bicarb. You don't get rid of hydrogen and you don't take back bicarb. Can you tell me bicarb in the blood is going to increase or decrease?
It's going to decrease. You said don't take back bicarb?
Yes. Here's what's a normal again. Understand this. Normal. Don't ever forget this. Basics. ABC kidney. Don't ever forget it. What are you supposed to do? Get rid of hydrogen, get rid of?
Potassium.
Take back
Bicarb.
and sodium. You're not doing the job. Okay? So you're not losing the hydrogen, you're not taking back the bicarb. Right? So what happened to the bicarb in the blood? You don't take it back. Decrease. So if I do a blood sample for you, what should I see? Acidosis and low bicarb. Do you understand why? So bicarb, decreased bicarb will tell me right away that the kidney is not doing the job. What if I do urine analysis, just to make it easy for you? Remember that you will see a cast anyway, right? Because of the tubules. But what will show up in the urine? Anything that is big. What is big? Can you tell me?
Cells.
Cells, any types of cells, right? What else?
Protein.
Protein. What else?
Sugar.
Depending on which sugar, yes. Like big sugar, polysaccharides. But protein is more important. But what else? Protein, cells, cells including red blood cells, white blood cells, platelets. What else should you see? Cast, which is red blood cells and proteins combined. What else? Bacteria. Isn't bacteria is a cell? Ketone is one thing, which is an end product of protein.
Glucose.
No, glucose is small enough it can go anyway. Glucose means diabetes. This is something else.
It's not supposed to go in the urine, it's supposed to go back.
It's supposed to leave and then go back. If you don't take it back, this is another problem. But I'm talking about the big stuff. Glucose is not big. It's monosaccharide. When I say big stuff, that will start to show up because the glomeruli are inflamed. Protein, the 3 types of cells, and bacteria. This is the most important of all. Okay? Isn't bacteria is big enough? The bacteria is like a cell, right? No difference. So urine analysis should show all big stuff. But in this case, there is no infection in the kidney. What did we call it again? Post-streptococcal? Is that infection of the kidney? Is that infection of the kidney or inflammation of the kidney?
Inflammation.
Is inflammation and infection is the same? Of course not. No, it's not. Infection causes inflammation. Other things cause inflammation. Inflammation does not equal infection. Don't confuse it. It's not. Inflammation means basically increased capillary permeability, like when your skin is inflamed. Do you remember when you inflamed, what happened? You see your skin like getting warmer a little bit, swollen a little bit, red, painful. This is inflammation. Does it have to be infection?
No.
Of course not. Can you have inflammation without infection? Yes, of course you can. So is glomerulonephritis is infection or inflammation? Inflammation that follow infection somewhere else. So this is not the issue. The question is it infection of the kidney?
No, it's the glomeruli.
No, it's not infection of the kidney. It's infection somewhere else. And it healed. It's gone. But after that, you have this complex settle in the kidney, starting inflammation. So should you see signs of infection in this case? No. Bacteriuria? No. It's not infection of the kidney. It's post-streptococcal. So albumin start to appear in the urine. And what do you call that? Albumin in the urine. Albuminuria. Okay? Albumin in the urine. So inflammation will increase the permeability of the glomeruli, like I mentioned before, decreasing glomerular filtration rate and causing congestion, so that albumin start to show up. This is a treatment. Here is one thing that's worth mentioning. So treatment, less sodium restriction, protein restriction. Basically, don't overload the kidney. Let me say it this way. The kidney is inflamed. Do not overload the kidney, right? If you take a lot of protein, you have a lot of waste products, the kidney will not get rid of it. So take less protein. Make sense? Take less protein. Do not overwhelm the kidney. But here's the problem. If you have this condition here, and I'm asking you, I want you to cut down on your proteins because you're overloading the kidney, right? If you cut down on the protein, you can get anemia. And this is the rationale, or this is the cause for people having glomerulonephritis to have anemia. Why? Besides erythropoietin, this is something else. When you cut on proteins, what's a red blood cells in the first place? Isn't it hemoglobin? Globin is protein, isn't it? So you'll have anemia. When you cut on proteins, you can have anemia. Otherwise, you take things for hypertension and glucocorticoids and so on. The next part is nephrotic syndrome. What's a nephrotic syndrome? Nephrotic syndrome is very close to the other condition, which is inflammation, or generally speaking, increased permeability of the capillaries. Okay? Sometimes, most of the time, it's idiopathic. What idiopathic means? Idiopathic. Pathic means pathology. Idio means self. That idiopathic simply means it's happening on its own, which is not true, by the way. The idiopathic here in the medical field they say idiopathic. What do you mean by idiopathic? It's happening by itself. What do you mean happening by itself? Translation: we don't know the reason. They're just embarrassed to say that we don't know the reason. But what do you mean by idiopathic? Right? This is just a nice name for I don't know. Idiopathic. What do you mean idiopathic? Like there is no change happening, no problem? There is a problem, and they will discover it later on, by the way. They used to say idiopathic on other things, and now they don't say it anymore. But anyway, idiopathic means we don't know. But sometimes it follow other things, like systemic lupus or nephrotoxins or something. In all cases, nephrotic syndrome is increased capillary permeability. When you increase capillary permeability, what will start to show up in the urine? Same thing. Proteins start to show up. Albumin start to show up. Lipids, I'm not saying fatty acid. Lipid is big, fatty acid is small. Are we following? What can show normally? What can be filtered out? Normally, monosaccharide, small. Fatty acid, small. Amino acid, small. Not polysaccharide, not lipids, not protein. This is a small unit of each one of those, and that's okay to be filtered out and you take it back. It's not okay for anything that's big. So what should you see here? Lipids in the urine, protein in the urine. Hyperlipidemia as well is one of the things, and I put a line under this because this is, when I ask you about nephrotic syndrome, what should you immediately tell me? Here it is, the bottom line. Number one, increase capillary permeability. Number two, the big stuff start to show up in the urine. Proteinuria, albuminuria, lipiduria, and hyperlipidemia. Lipiduria, hyperlipidemia. Are we following? Are we following what's going to happen? Proteinuria, albuminuria, lipiduria, proteinuria, albuminuria, lipiduria, hyperlipidemia. Hyperlipidemia. Okay? So you will see all of those, including also a cast in this case. And the treatment is, always the treatment is glucocorticoids involved because it's anti-inflammatory and other things. Now urinary tract infection. Erythrolithiasis. Urolithiasis, what does it mean? Lithiasis means calculus or stone. Lithiasis, calculus, stone is the same thing. Lithiasis, calculus, stone. So this is a stone or calculus that develop anywhere in the urinary system. And it's 1 out of 2 basically. Why anybody will get a stone? 1 out of 2. Either the solute is too much, so the urine is concentrated, or the water is less. Are we following? Here is the bottom line. If the urine is too concentrated, you can get stone. How is the urine be concentrated? When you add some salt to water and dissolve, you call this solution, right? The salt is a solute, and the water is a solvent, right? When you have less solvent, it's concentrated, right? If you have more solute, it's concentrated. So you have 2 conditions for the urine to be concentrated and to make stone. Either the solute is too much, let me be very specific here, calcium and uric acid. Hypercalcemia and hyperuricemia or uricemia. Are we following? Specifically. Hyperuricemia, hypercalcemia, and hyperuricemia. You know why I'm mentioning those 2 specifically? Do you know why? Because the stone is usually either calcium or uric acid stone. Did you understand this? Okay. Or insufficient fluid intake. Both of those, this and this, mean the same thing, which is urine is more concentrated. Infection can also lead or help the process of formation of the stones. Okay? So now what if you have a stone that's closed or obstructed something? You can have infection because of that. You can have acute attack of renal colic. If the stone is obstructing the ureter, what will happen to the ureter? The ureter have muscles. It will start to contract, try to push it out. And this contraction, you feel pain because of that. Okay? So this is renal colic, if it is in the urine. Hydronephrosis, if the stone blocked the ureter, you start to have hydronephrosis and hydroureter. This is hydronephrosis, dilation. See how this is dilated? Look at this. The calyces are dilated. Hyperuricemia, hypercalcemia. Remember that. Hyperuricemia, hypercalcemia. Why? Because the stone, most of the time, it's either calcium stone or uric acid stone. There are other types of stone, something like stovit and cystine stone and so on. Stovit stone is something like a big stone, different, but again, what is the most common? What is unique? This is the name of the game. This is how to play this game. What is the most common? What is the unique? What is the most common here? Hypercalcemia, hyperuricemia. Why? Because most of the stones are calcium or uric acid. Okay? Do we have other stones? Yes, but this is the most common and most important. Usually the stones are asymptomatic. Why? Do you know if you have stone or not? You don't know. You only know if you have stone or not if it started to move or if it's blocking something, right? Before that, it's asymptomatic. You never know. You don't feel it until it starts to move and causing something like renal colic. Renal colic will be here in the flank area, but usually radiating to the groin. And this is something unique here. So do you have pain here? Yes. Add to that, because of the ureter, it will radiate like this. Because of the ureter, goes like this. Okay? Not just in the kidney, the ureter. So I feel pain here, and I feel like the pain is shooting like this to the groin. Okay? So this is something unique. What's the fate of the stone? It depends on the size. If the stone is too small, it can pass in the urine and you get rid of it and you're done. If it is big, it might need surgery or infrared or something to get rid of it. So it depends on the size. There is something called the ESWL, which is the extracorporeal shock wave lithotripsy. Again, treatment is not the most important thing. You can read it for your own information. It's not the most important thing. But there is a machine that submit waves to go to the stone and break it down into smaller parts, which pass in the urine. Hydronephrosis, I mentioned that. Accumulation of urine in the kidney. If it is in the ureter, you call it hydroureter. So what can make hydronephrosis? You have to remember the reasons. You have to memorize this. What make hydronephrosis? What hydronephrosis? Accumulation of urine in the kidney. Why? Because the passageway is blocked. Blocked by what? Remember it. Maybe stone or calculus, right? Didn't we just mention that? Stone moving, blocking the ureter, the urine doesn't leave, right? So this is one. Maybe tumor or scar tissue, like if this person is having a tumor in the ureter or close to the ureter, pushing it, closing it, anything that block the passageway lead to hydronephrosis. What can block? Calculus, stone, tumor, scar tissue, even pyelonephritis. Inflammation can constrict. Okay? How about untreated prostatic enlargement? Look at this here. If the prostate is enlarged, it will constrict the urethra, right? So the urine doesn't leave. Start to accumulate. Did you understand the reasons? So you need to memorize this. Sometimes it's developmental abnormalities, and usually hydronephrosis will be asymptomatic in the beginning until you start to have the symptoms. Renal cell carcinoma. Renal cell carcinoma, what do we need to know about it is, this is primary tumor, meaning it's not coming from somewhere else. It starts from the kidney, primary. Which part of the kidney? From the tubular epithelium specifically. Okay? Most of the time it's asymptomatic, and it's more in men smoking. And usually the treatment is they remove the kidney itself, but renal cell carcinoma is more frequent in men, specifically smokers. And what's the first thing that show up? Again, when you see something specific, you have to remember it. Okay, I'm not reading everything, by the way. I'm not reading the slides. I'm focusing on the unique more. So what's unique here? Painless hematuria. Painless. Why I'm mentioning painless specifically? Because if it is painful, it can mean something else. It can be stone, calculus, infection, all of that is painful, isn't it? But this is painless, painless. So the tumor, the cancer in the kidney is causing some drops. Most of the time it's microscopic hematuria. What's microscopic hematuria? Like you have the urine like this, the urine is not red. You see just a little bit, very tiny amount because there is no actual injury. It's the tumor is just causing this microscopic hematuria. And obviously the pain will be in the flank area if it develops, but it will be dull aching, not excruciating or severe pain. What's dull aching means? It means like this. I have some like pain a little bit here, like heaviness, something like this. Not like I have severe pain, I have to go to the hospital. This is something else. Okay, like stone, like infection. This is something else. It's dull aching. Besides weight loss and anemia and other things. Tumor of the bladder or bladder cancer. Unfortunately, if somebody is having a bladder tumor, most of the time it's cancer automatically. Same thing as the testes, unfortunately. Do you have a tumor in the bladder? Yes. Usually it's cancer. Not 100% of the time, but usually. What happened in early stages? You start to see hematuria, dysuria, and maybe infection, and then the tumor will start to become bigger and show other problems. Bladder cancer specifically with people working in chemicals laboratories. So if this person is working in the laboratory dealing with chemicals or in the chemical factories, you're working in one of these chemical factories, have more chances, and cigarettes. So cigarettes and chemicals, if you're exposed to one of those that irritate the bladder enough to cause cancer of the bladder. Now vascular disorders. Vascular disorders meaning the vessels of the kidney are affected. Nephrosclerosis. What sclerosis means? Hardening and fibrosis. Remember it this way. Hardening and fibrosis. Or hardening by fibrosis. Always remember it combined. Thickening by fibrosis. Hardening, thickening, fibrosis. Okay? So thickening and hardening of the small arteries, like arterioles. Small arteries and arterioles. And if that happen, obviously, if that happen, so the blood vessels are like this, okay, it will become thicker, so the lumen will become smaller, right? Less blood go to the kidney, renin, hypertension. So nephrosclerosis leads to hypertension. If nephrosclerosis continue, it will start to destroy the kidney, leading to chronic renal failure. Chronic or acute? Chronic. Can it be acute? No. It cannot be acute because this is it's not something that's happening all of a sudden. It's chronic. It takes time to build up. By the way, I'm putting step by step for the renal failure as we go. So you need to remember this. And the bottom line is, think about it. Ask yourself, acute or chronic? Ask yourself, is this something that's happening gradually, over time? Chronic. Something acute, happening all of a sudden, that will be acute renal failure. So, here is an important question here. Nephrosclerosis. You have hypertension. Why? This is an important question. Nephrosclerosis, you have hypertension. Why? 2 reasons. Or it's the same reason basically. What's a nephrosclerosis? Sclerosis is? Hardening and thickening. Hardening and thickening by fibrosis, right? So when you do that, less blood go to the kidney. The kidney release what? Renin. And renin lead to? Did you write this? Did you take this? Okay, so Anytime you see renin, hypertension, right? So why do you have hypertension in nephrosclerosis? Renin and aldosterone. Aldosterone also will be released. Okay? What else can happen with nephrosclerosis? If this is not treated, the kidney tissue will be destroyed by time, leading to chronic renal failure. Now, congenital anomalies or congenital disorders. Vesicular reflex, I talked about this before. Viscous cystitis in? It's still here. Vesicular reflex. Causes cystitis in what? Who can have this problem? Is the urine supposed to go from the ureter to the bladder and backward?
No.
What if it goes backward?
Children.
In children, it's vesicular reflex. So this is one. The other one is agenesis. A means a. A prefix that means not. No, not. A means no, not. Genesis means generation. Means no kidney. You don't have kidney. Agenesis, you didn't make kidney. Okay? And it's usually one kidney. Can it be two kidneys?
Yeah.
He will die. He will die. He will be stillbirth, born dead, or will die immediately. So it's usually one kidney. And by the way, one kidney is enough to do the job if it is healthy. So what this child complained? Nothing. One kidney is enough. One healthy kidney is enough for any person to survive with no problems. He doesn't even complain about anything. And by the way, this should be discovered accidentally. Well, like, let's do ultrasound or something. Oh, do you know that you have one kidney? I didn't know. Because he's functioning. So most of the time it's asymptomatic. Okay? Hypoplasia is a smaller kidney. Ectopic kidney is kidney in an abnormal location. Horseshoe kidney that looks like a horse show. But anyway, what's the most important? This and this. Okay? You can read whatever you want, but you don't forget what I'm focusing on. Okay? So what should you focus on in the congenital anomalies? Vesicular reflex and agenesis. Okay? The adult PCK, which is polycystic kidney, this is an adult who have multiple cysts in the kidney. So the kidney will become what? Larger because of these cysts inside. This start to compress the kidney, leading to degeneration. What kind of renal failure is that? Acute or chronic? Chronic. You don't have like, today I'm fine, and tomorrow I have multiple cysts, and the kidney is destroyed. Of course not. Right? It starts to enlarge time after time after time, compressing gradually. It takes years for the kidney to fail. You should see it with the CT. Here's how it looks like. Okay? See all these cysts will cause compression and chronic renal failure. One of the tumors specifically is called Wilms tumor. And this is the most common tumor in children. Remember the adenocarcinoma? This is in adults. In children, it's Wilms tumor. Most of the time, it's unilateral. And the unique thing that I always focus on is this. It's large, encapsulated. This is not something usual. This is unique. What does it mean? It means the tumor is like this, within a capsule. If you see a tumor in a kidney of a child that was in a capsule, it's done. Wilms tumor. Did you get the unique part about it? Now, renal failure. Renal failure can be acute and can be chronic. And this is the last thing that in this chapter. Acute renal failure versus chronic. Acute renal failure, something that's happening acutely. None of what we mentioned so far, right? None of it. Something that's happened all of a sudden. So this is something that happened acute. Can it be acute problem with one kidney? No, this is not failure. If you have one healthy kidney, I don't call it renal failure. So it has to be bilateral. Bilateral. Both kidneys. Otherwise, if you have a problem with one kidney, it's not renal failure. Renal failure means the kidneys failed to do the job. If they don't fail because you have one good, I don't call it renal failure. So for renal failure, it has to be bilateral. Bilateral, something like glomerulonephritis that we talked about before. It has to be bilateral, destroying it if it is severe. These causes are extremely important to memorize and remember. You have to remember this. Something that's happening all of a sudden. By glomerulonephritis, for example, it happened maybe today you have this inflammation started today, tomorrow it will start to affect the kidney, right? This is something acute. Circulatory shock, like this person is having today. He's having a problem with the heart all of a sudden. He has shock. This shock means less blood going to the kidney. It can lead to renal failure. So think about it this way. A person who's having an accident and crushed or burned his kidney, does that something that takes time? You make an accident, you crush the kidney in a minute, right? So this is acute, isn't it? Mm-hmm. Does it need time? Burn, same thing. Nephrotoxins, like a child who takes something like acetaminophen, for example, take the whole bottle. Tomorrow he will have renal failure, okay? If he didn't have treatment. Or anybody, suicide. Take something that's nephrotoxic. Whether this is medication or chemicals or toxins or something. So this is the most important. Sometimes it's a mechanical factor, which is kind of hard. Something like calculus or blood clot. This can also block the urine out and lead to renal failure acutely, but these are the most common causes. What the first thing that you see? Kidney is failing acutely, so the kidney is not doing the job. One of the most important jobs is to get rid of the waste products, so it will start to accumulate. Urea, creatinine. See how many times I repeated those? Mm-hmm. So you have to remember this. These are the organic waste products, nitrogenous waste products. The other thing is metabolic acidosis and hyperkalemia. Can you tell me why? I mentioned that several times. What's normal? Get rid of? And when you don't get rid of it, what you get? Metabolic acidosis and what else you're supposed to throw in the urine? Hyperkalemia, right? Is that too hard?
No.
What do you normally do? Get rid of hydrogen and potassium, retained by carb and sodium, right? You're not doing the job. You don't get rid of hydrogen. You don't get rid of potassium. Hydrogen and potassium accumulate. Acidosis and hyperkalemia. What's the problem with hyperkalemia? Let me tell you this. Which one is more dangerous, potassium or sodium? Change in potassium or sodium? Potassium is more dangerous. Hyperkalemia, hypokalemia, both of them can lead to heart attack. Both of them. Hypo or hyper. Hypo or hypernatremia is not that bad. It's going to affect the osmosis. It has some effects. But potassium, it's horrible. Whether it's high or low, hyperkalemia, hypokalemia, both of them can lead to heart attack, dysrhythmia, arrhythmia, dysrhythmia, whether hypo or hyper. But in this case, it's hyper, okay? Acute renal failure. Treatment, treat the cause, diagnose, it might need dialysis. Is that temporary dialysis or permanent? Temporary until you heal. How about chronic? Chronic is something that's happening over time. Okay? Causes are extremely important. Chronic kidney disease. See, chronic. So this, like pyelonephritis, for example. Pyelonephritis, if it is chronic, it can cause this. Congenital polycystic kidney. Did we mention it when we talked about the polycystic kidney? Of course, it doesn't, like the cyst, it doesn't like appear today and tomorrow is going to destroy the kidney. It's something that takes time. Systemic disorders, you have to remember those. Something like diabetes, nephrosclerosis. Did we talk about nephrosclerosis? Acute or chronic? Chronic, right? Hypertension, chronic hypertension, chronic. Diabetes, hypertension, nephrosclerosis. What's the problem with hypertension specifically? The afferent arteriole will be destroyed, can be destroyed, damaged, leading to renal ischemia, chronic renal failure. How about nephrotoxin? Did we mention that nephrotoxin cause acute? Right? I'm going to commit suicide. Take a nephrotoxin, whatever it is, and take it tomorrow, maybe today, I have renal failure. This is acute, right? How about this? You take something bad on a daily basis, but small doses. Isn't that going to take some time? Maybe a couple of months, a year or something? Yes, so nephrotoxins, it depends. Is it something that's severe, high amount, or frequent, small amount? It can cause both of them. Now you need to know for chronic renal failure, is that an early stage or late stage? Is it the beginning of chronic or later on when everything is gone? If it's in the beginning, you will see decreased glomerular filtration rate. The kidney started to fail, and the kidney is supposed to reabsorb water, right? You don't reabsorb water, so you have polyuria. You make more urine. Polyuria, that's diluted urine. Is the urine supposed to be diluted? It's not supposed to be diluted. If it's diluted, meaning you're not taking the water back, right? So if the water is urine is diluted, it means you're in the process of failing. Erythropoiesis will decrease, anemia, hypertension, increase urea and creatinine, and this is one of the indications for renal insufficiency. Renal insufficiency. Is that end stage? No, renal insufficiency means it's working but not sufficient. So this is the beginning, right? So urine and creatinine is going to accumulate, and this means it's early stage. How about the end stage? Glomerular filtration rate is almost nothing. Almost. Negligible. Very low. Almost nothing. Okay? All things that are supposed to be wasted in the urine, supposed to get rid of it, will accumulate, right? And then you have the 3 A's. Azotemia, anemia, and acidosis. This is at the end. Remember, we have polyuria, now we have oliguria, or anuria. You stop making urine completely. Very small amount. This is at the end. At the beginning, do you get the difference? At the beginning, you actually make polyuria. A lot of urine. The kidney started to fail. So it's working, but it's not conserving the water the way it should. So make more water that's diluted, right? Later on, when the complete failure occurs, nothing even goes through it. So there is no urine. Or oliguria. And then uremia. Uremia means uric acid accumulate, or urea accumulate. Aren't you supposed to get rid of urea? This is end stage. The kidney is not doing the job at all. So now urea and creatinine are going to accumulate enough that you call it uremia. Uremia is renal failure end stage. You will also have some problems like hypocalcemia. Why? Because remember in the first slide when we said one of the functions of the kidney activate vitamin D? You don't activate vitamin D anymore, hypocalcemia. And hyperphosphatemia is something that follow that. Uremic signs, when the uric acid accumulates a lot, you have something called encephalopathy. What's encephalopathy? Urea and ammonia accumulate enough to go to the brain, affecting the brain, and this is called encephalopathy. Osteodystrophy. The kidney is not making vitamin D, so there will be problems with the bone. Azotemia means a lot of urea and nitrogen in the blood. Azotemia. Azotemia. Azot means nitrogenous. Azot, nitrogenous waste products. So nitrogenous waste products accumulate, right? So how to treat this? The kidney is gone. Nothing that you can do. So what should you do? Dialysis until you have kidney transplant. If you don't have kidney transplant, it's forever. You usually do it 2 to 3 times a week. So at the beginning you have polyuria and you have lethargy. And here is the cause. Why in the beginning you have some headaches, anorexia, and lethargy? It's because increased blood pressure, serum urea, anemia, and acidosis. All of those combined will cause these early signs. And this is something that you need to know. What cause the early signs? What are the early signs? Early signs include all of these and polyuria. What is the cause? This is the cause. Anemia is because of bone marrow depression and then hypertension. If there is a complete failure, I told you already what's going to happen. Now, instead of hypertension, you have hypotension. Are we following? Polyuria is early. Oliguria or anuria is at the end. Hypertension is early. Hypotension is at the end. Acidosis. You know the acidosis by, what do you call, what's the normal pH of the blood?
7.4. 7.4.
It's all 7. If you want to say 7.4 plus or minus half, you have to say it this way. You can't say 7.4 because 7.4 means I am 7.42. Am I having a problem? I am 7.36. Is that bad? No. So either 7.35 to 7.45 or 7.4 plus or minus 0.5. These are the two ways. If it goes under 7.35, what do you call it? Acidosis. So if you wanted to know if there is acidosis or not, you need to measure the pH. Diagnosis is the 3 A's will show up, and you can test that in the blood. Treatment, I mentioned it. And this is just comparing the two together, putting all of these just to compare it, and we covered all of this. So you can use this table to know the difference between acute and chronic renal failure, but we covered it before.